Well, hello everyone. Welcome to it's already episode 6. Unbelievable. Oh my gosh, episode 6 of the Caring Neurologist. I'm going to start off by congratulating Dr. Sandeep Thakkar because this podcast is doing really well. It's actually number 1, number 2, number 10 in many countries. So Dr. Thakkar, congratulations.
Thank you. I don't know what to say about that because for us, the endeavor is education and spreading knowledge. And for the shortcomings so far, we've gotten great feedback from patients, been at support groups that people started listening in on. So as long as we're touching lives and improving the awareness of how to help neurological care, then we're doing our job.
I was actually going to tell you that you doctors, when you study to be a doctor, before you thought you saved lives or you helped people only in the consult. But now you can do so by doing things like this, which has to be very touching.
Yeah, I felt like the aspects of medicine continue to evolve and change, and you get maybe burnt down by the bureaucracy and insurance. But at the core of it, am I happy doing what I do? Yes, I am. Someone asked me, would you change your field? And this was a patient who had Parkinson's. And I said, I wouldn't change because despite all the difficult stories and cases that people go through, we're still touching people's lives. We're still promoting good quality of life. We may not have a cure yet, but we're still able to restore function, and people aren't as disabled, or they're not as worried about their symptoms. We're able to control their disease state. I think we're giving back where I thought we never could. So it's been exciting.
I think we talked about it on the previous episode that Parkinson's is not a death sentence anymore, and it's not a diagnosis that people have to. Of course, it's not a wonderful diagnosis, but it's not what it used to be.
It's true. We're day and day getting in more research, learning about genetics. We're getting newer medicines, and so therefore it's not as daunting to swallow that diagnosis, once you get it. But today we got some exciting stuff to talk about, some stimulating stuff to talk about.
Yes, we do. Let's go and get right into it. Today's episode number 6. I cannot believe we're already on episode 6. Is DBS, Deep Brain Stimulation.
Deep Brain Stimulation.
And how it actually does change lives. And I'm going to start asking you the first question. Let's go right ahead. And so Deep Brain Stimulation sounds kind of, like science fiction and futuristic, and maybe it's even scary for some people. So I am hearing about it for the first time. So how would you explain DBS to someone that's, such as myself, hearing about it for the first time?
So, like yourself, the first time you're hearing about it, but deep brain stimulation, is more like targeted brain stimulation. The deep part sounds very daunting, but you are actually stimulating areas of the brain to control and correct for motor symptoms. So it is daunting. So deep brain stimulation is on multiple levels. We have to kind of break it down. The brain itself is getting signals by natural chemicals, and we are sending chemicals throughout different pathways. And in the world of Parkinson's, we use dopamine to send certain pathways of signals to coordinate whether so we don't have a tremor, and maybe we're not so stiff. So when we take medicines and it gets converted in our brain to dopamine, now we can fire and those signals work well. And we think of it as a circuit. So everything works and sends a signal, just like the heart. The heart is electrical and it's all circuits. And if the heart doesn't function well, then we get a pacemaker because we need to send those signals. Now, in the brain, specifically for Parkinson's, we have numerous targets that we can actually stimulate. We can actually stimulate these areas and either correct the circuit or kind of jumble up the abnormal circuit. So with Parkinson's, when we're low on dopamine, we've actually, for years, actually, this has been for decades, we've known that we can stimulate an area of the brain with a tiny little wire, and we can put that implantable wire into that area, and we're able to now recorrect that circuit that is low on dopamine or was depending on dopamine. So again, it sounds daunting, but deep brain stimulation has been around for years, decades, and it's allowing the area to function and smoothly like it should. So it's actually very simple and involves the nuances of a surgeon, myself, and a team to kind of get this activated.
I was telling you that I understand the concept, but how does DBS work exactly in the brain? What is it exactly that is done to the brain or in the brain, and what are the symptoms that it can help with?
Sure. So deep brain stimulation, as I went back to the basics, I want to make sure everyone understands this, because there are people who've had Parkinson's for 5 years and 10 years and 20 years, and they've never heard of deep brain stimulation. So also known as DBS. We use this acronym all the time, and sometimes it goes over people's head, but it's actually a very simple way of, we get an actual generator or battery, and we actually implant it like a pacemaker under the skin. And there's tiny wires and connectors that go under the skin, and we actually stimulate into an area of the brain. So you actually have to have a procedure. This is actually a surgical intervention where we make an incision with a neurosurgeon, and then we open up the skin and we make a tiny little burr hole, so to speak, in the skull, and we cover it back up. But we are actually implanting a lead into an area of the brain that we know that has abnormal circuits. Now, as time has gone on, we actually even know the abnormal waves of the brain. We know how the brain works. We know how it signals. And we've been able to then stimulate those areas with this generator. So a patient will come in to see us after they've had the implantable generator implanted with the surgeon. They'll come to see us outside of the clinic, and then I will have a special like iPad device, a clinician programmer, and I can actually adjust the signals and send actual frequencies and amplitudes to deliver stimulation to that area of the brain. So like I said, it's a circuit that the brain works on. It's low on dopamine, so it's not firing well. And then when you come to see us, there are going to be certain patients who are candidates for this surgery with Parkinson's or essential tremor or other dystonias. And then we determine if they're a safe candidate. And after they've been evaluated for the surgery based on certain symptoms and criteria, we'll have them go through the process, come in to see the surgeon. The surgeon will implant the device. They'll come back to us, and then we'll program the device based on where their symptoms are. And it's, again, we'll have to break it down in this episode into each part, but there are a lot of symptoms people suffer from. And what DBS does, it targets motor symptoms. So people who have tremor, stiffness of the muscles, it can help with slowness of the muscles. It does not help at this time for balance issues or freezing of gait where people are walking and they get stuck. It doesn't help that. But I have some interesting stories of patients who we've had improvement with certain aspects of walking.
Okay, so 2 questions pop right into my mind. Number 1, you say this is under the skin, right? Does anybody who doesn't know the patient notice this? Is it something that it's seen from the outside?
Yeah, no one can see it. So it's all under the skin. Now, maybe if you have a thin frame, maybe like the battery can seem like it's protruding kind of like a little bit of a bone, but it's all under the skin. And even if the wire is under the skin, it looks like maybe a vein, right?
Okay.
So it's all under the skin. Patients get this. We've had over 200,000 patients in the world actually get surgery. And this deep brain stimulation surgery, patients can now live their life and travel, so they can go through, TSA and different airports, and it again allows for them to get their life back.
Well, I was actually going to ask you about that. That was my second question. What kind of, I mean, can they go through a TSA scanner? I mean, because you do have like wires. So what kind of
Yeah,
things?
and it's it's simplified. This has become very simplified where you have this little implantable generator, and just like how someone has a pacemaker, they may have a card saying, "Look, I have a cardiac pacemaker." Patients get an actual deep brain stimulation card and say, "Look, I have a generator." And as we have learned from other fields, there's urological conditions that require a bladder stimulator. There's pain stimulators for the back. There's also uh, stimulators for the GI system, so you can actually stimulate the gastric system for people who have diabetes and they're having issues with constipation. So we have a lot of stimulators. I mean, the human body is probably going to become robotic in the future, and AI is going to take over everything. But with the deep brain stimulators, yes, it's been something that you don't have to shave your head anymore. This was a fallacy that you have to go shave your head. You don't even have to shave your head. It's not like focus ultrasound. Focus ultrasound is another brain procedure where you actually have to shave your head. Here, we don't even have to shave our head.
Okay, so is DBS a last resort when everything fails, or how does it work? When should someone start considering DBS?
So someone should consider deep brain stimulation not in the beginning and not when it's too advanced. You actually need it when everything's functioning well and working well, but we're having difficulty with the meds not being able to control all the tremors and all the rigidity and aspects of slowness. So when a patient is taking carbidopa, levodopa, or typical dopamine therapies, and it's working to a certain extent, but not sustaining, and we're needing more and more pills, then that's when you become a candidate for the surgery. So you have to be responsive to levodopa, number one. You could develop what's called dyskinesias, as we've talked about in previous episodes. For instance, those involuntary twisting movements of the body where people are constantly writhing. That may be when there's medicines kicking too much because we're giving too much medicine to control for symptoms. People can develop that. And that's when we call it fluctuations. And that's when also you're a candidate for surgery. You do not have to have tremor to be a candidate for DBS. Like patients, even 20% of people who don't shake, they can still be a candidate for DBS. You don't have to have dyskinesias, but when the meds are kicking in and wearing off, then you're kind of struggling in your day-to-day with quality of life, and then you become, a better candidate for this surgery, because we know that in these areas of the brain, you have to be somewhat dopamine responsive. And if you are dopamine responsive, then we can stimulate that area and then minimize the dependence on pills as well.
Okay, so please take me through the DBS process and what it actually looks like. So from the evaluation to the, yeah, you are a good candidate to surgery, to post-surgery programming, what's the typical timeline for seeing results? Are the changes immediate? Is it something like happens overnight, or do they unfold over time?
Great. So this is we'll dive in here. So number one, I just want to say, like, one of the reasons why I switched from going into epilepsy as a neurologist into movement disorders, outside of the stress of my mom, losing her, I was captivated by technology in medicine and in neurology. Neurology, we're able to give diagnosis. We're like, okay, we can think and figure out things, but we weren't really able to, like, here, take this and we can fix this problem. Right now, we're still far away from certain cures, but when I was younger in my residency days, a patient came in who just had surgery, and he was shaking significantly, and he had just had the surgery, and I was able to actually help program him, and we were able to get rid of his tremors, and that, like, just opened my eyes. So deep brain stimulation is one of the key factors what brought me into the movement disorders world and being a Parkinson specialist. So I owe a lot of my where I'm at right now to this technology. The second aspect about this story is that, it felt like the dependence on pills for patients reduced significantly after having surgery. So we're able to kind of turn back the clock in a way. So what happens is a patient will come in and saying, look, I'm having a lot of medicine. I'm getting tired from the medicine. I get dizzy. I'm having dyskinesias. My symptoms are still there despite taking numerous medicines. So we say, okay, well, let's evaluate you by doing what's called an on-off testing. So we videotape you on medicine when it's working and how good you are. And then we videotape you off medicine and see how bad you are. And then we actually score patients and say, look, patients better with medicine and they're worse without it. And then we see a certain percentage on our scales, our movement disorder scales, and say, okay, this is a 25% improvement, a 30% improvement, a 60% improvement. And then we have the patient also go for neuropsych testing to make sure that there's no dementia, make sure that there's no behavioral issues, because you can't have underlying depression or psychosis or any complications from the mood aspect, because deep brain stimulation can also maybe aggravate certain areas. After they've had the neuropsych testing, then we'll also determine like which part of the brain are we going to stimulate. There's several areas we can choose from for Parkinson's that we can say, okay, we're going to implant the lead into this part of the brain called the subthalamic nucleus, or another part called the globus pallidus. So there's two areas that we can stimulate to help control the motor symptoms. We also evaluate patients who don't have Parkinson's with like essential tremor and dystonia and other aspects of the brain. But for Parkinson's, these are the two main areas that we stimulate with the lead, where we implant. And then after we decided that this person's a good candidate because of their symptoms being controlled or not, with meds, we send them to the surgeon. The surgeon will talk to the patient about risk factors, the risk factors like stroke, a bleed in the brain, an infection, maybe even seizures, the risk factors of how long they're under anesthesia, how long the surgery is going to be for the patient for the first part where they implant the lead, and then how they put in the pulse generator, and then how they stay overnight. And then the patient will then come see us a few days later or up to a week or two later. Now, there's times where we see the patient even a month later after deep brain stimulation, because we let the area of the brain kind of heal. We let all the kind of everything settle. We let all the stitches heal. And then the patient will come to us. And then what we do is we connect through Bluetooth to their implantable generator, and we have a device that we can then stimulate, change parameters. And it takes somewhere about 2 months to 6 months to really hone in on the right stimulation pattern. So we actually have the patient come back numerous times to our clinic. And as we're going up on the stimulation, we're going down on medicine. So we go up on stimulation, we go down on medicine. And it becomes a pattern where we're reducing the medicine. There are people who actually are off medicine altogether for Parkinson's disease because we can stimulate the areas of the brain.
This question might sound pretty stupid. I apologize beforehand. The doctor is the only person controlling what's going on. I mean, this is not something that the patient can do at home and say like, I'm having tremors, I'm gonna switch. That's not something that.
That's an excellent question, by the way, and it's definitely not a dumb question. It's a great question. So what ends up happening is we will start off with delivering a certain type of patterns, and conventional DBS, as opposed to the new age DBS called adaptive DBS by Medtronic, that's a different type of technology that is enhanced and kind of on cruise control or autopilot for stimulation. And we'll talk about that in detail. But the clinician, like myself, will set certain parameters, and then we're able to give the patient actual ability to adjust their settings based on their symptoms. So, for instance, I work with a company called Medtronic, and Medtronic they're the leaders in the field for brain stimulation, and they're highly involved in pain stimulators and cardiac world. But a patient will get a phone, for instance, and that phone that they can actually then connect to their stimulator, and they can adjust their own frequency or amplitude based on what parameters we've given them. And then if they're shaking, they can then press a stimulation to then account and adjust for it if they need to.
That's amazing.
Now, that's really impressive, and it's amazing, and it's actually very intuitive. They made it very simple for patients. So Medtronic has all these resources that have made life easier for patients. And there's two other companies that are also involved that are in the brain stimulation space, and they've also made things unique for patients. What Medtronic has done is they've made it even much more advanced. They've created something called adaptive deep brain stimulation, so ADBS. And ADBS got its approval early this year in the context of where we can now actually sense the brain waves. Like, we actually have these leads that are in the brain that we know that are abnormal rhythms. We call them abnormal beta waves and abnormal theta waves. And we can sense all the abnormal rhythms, and those rhythms can then be targeted, and the actual stimulator is smart enough to then send the signals based on what parameters we're looking for. So if a rhythm is abnormal and syncs up and it causes tremor, the actual stimulator can then just dampen that signal based on how we've set the parameters to deliver it.
That's unbelievable. I'm actually in awe. But it is, I mean, it is brain surgery. I mean, and it does sound kind of intimidating. Surgery sounds intimidating. Brain surgery sounds even more intimidating. So, what would you say? I mean, everything sounds amazing, but I do think that some patients may be afraid of undergoing brain surgery. So what would you tell them?
The aspect of deep brain stimulation is always daunting when you start going into the aspects of, yes, it is a surgery. First thing we have to talk to them about is, why do we even consider it, right? You have motor symptoms, you have tremors, you're taking too much medicine. We're countering these problems you're having, because deep brain stimulation isn't a cure, but it is still a way of managing patients and giving them the best option. We're getting them to the real time where the brain is actually saying, I'm having an abnormal signal, we can dampen it. And they're getting signals in their brain to actually go back and restore to a certain normalcy. And so imagine, Ursula, if someone is having a seizure, right? They're actually having a seizure and they're convulsing. The brain's actually sending an abnormal signal that's then firing to other areas to create motor spasms, right? This is what's happening in different circuits of the brain with Parkinson's. There's little seizures, so to speak, that are causing a tremor, and we can then just dampen those signals so then someone doesn't tremor, or isn't as rigid or isn't as slow. So for patients, we have to go back to the basics of, this is going to control your symptoms, because we've seen and have evidence over so many years that you don't have any red flags. You're not falling all the time. You're not having hallucinations. You're not having behavioral issues. We have to make sure that there's certain red flags are not there in a patient. And we have to make sure that they're responsive to levodopa and are getting response from meds. And they have to know that there are risks, and these risk factors, again, as commented earlier, is there's risk of infections. And yes, we can give an antibiotics and that can fix it. Yes, they have to go under anesthesia for a couple hours. They have to understand that there's going to be an incision and a scar on their skin, but that typically heals. We have men and women who have this surgery, and we've seen them after surgery that they may have stitches, they may have even staples, and then those are removed after a week or two. They have to know the timeline, that is maybe 1 or 2 weeks that they have to take off from work. So these are things that are daunting. You have to plan accordingly. But when we start bringing up deep brain stimulation for patients, this isn't something like we tell them and it's like, you have to go tomorrow. Like, this is a planned, we need to talk it through. It sometimes takes 6 months to 12 months to really initiate and get the process going. But as patients talk to others who've had the surgery, we get people to go and talk with others at support groups, or we have them get an evaluation with the neurosurgeon, or they'll get a second opinion, and they'll come back to us. And then we'll keep this conversation going. So by no means do we want this to be a last resort. This is not meant to be when you can't walk, when you're bedbound. This is when you're active. We need to implement this when people are already active. And so when the rest of the body is functioning well, and we just need to control those areas of the brain, we want to implement this surgery and let them know that, yes, there are risk factors of bleeding. I mean, this is a brain surgery where it's been targeted. We know exactly where we're going. We do imaging of the brain, so we know what the vessels are, so we're not going to create a bleed. And it's also we're also sending patients to the right functional surgeon who is trained in this, who has years of dedicated time for this procedure. And it's not like taking out a tumor where there's a risk of more bleeding or creating a stroke. We're just actually literally implanting a lead that's like the size of a spaghetti string into a very particular area, and we know how to target it based on imaging. So once the lead is placed, we also have special recordings to know that we're in this right area. And we even evaluate the patient while they're in anesthesia. They kind of actually minimize the anesthesia. The patient wakes up in the surgery while the lead is there, and they can actually open and close their hands. They can try to move it, coordinate, and then we can turn on the stimulate in the surgery. And patients, I mean, we have videos of patients that are actually in surgery and they're shaking. They turn on the stimulator. Now they can actually now coordinate and even play music while they're in the surgery, because we want to make sure it's working and functioning well. So it is daunting. This surgery could also be fatal. There's a low risk of it, but still, we do have to make sure that patients know all those potential complications.
Okay, I do understand about the risks. It is a brain surgery. What about side effects?
So we're stimulating areas of the brain for motor control. So those motor control areas, if we're stimulating maybe more than we need to in that area, maybe patients feel some facial twitches, or they may feel some speech being a little bit more hoarse. They could get from the stimulation, maybe like some degree of muscle tightness, because we can overstimulate when trying to control the tremor. So those are stimulation-induced issues. So we call it dysarthria when it's the speech. We typically don't get like a vision problem. Their vision still maintains, but maybe they can see little floaters if we're stimulating a little too much in certain areas. Sometimes we can overstimulate. They get contractions where the face is actually pulling, and then we just lower the stim, and now they're back to normal. So the good thing about this is there are parameters. This is not permanent in the context of we can adjust the settings, and there's so many different settings that we can do to program. So when it comes to stimulation induced side effects, we just lower the stimulation if we have to, and then dampen that down. Going back into more kind of complications, the wire that's under the skin, maybe they can have erosions of that. The battery itself has a timeline on it. Just like anything, you have to get the battery replaced, and they make a little incision. They take out the battery and they put a new one in, and then they reconnect it. There's also different types of batteries or implantable generators that are rechargeable. So actually every week a patient, or every 2 weeks, a patient may charge their stimulator, so they don't have to worry about going for surgery every 5 years to get it replaced. The rechargeable batteries are 15-year life. So the patient would, just like you charge your phone, you would charge your stimulator once a week, once every 2 weeks. And some patients even charge it every 3 weeks, depending on how much stimulation they're using.
Unbelievable. But do you think that you did say that it had to be not a very advanced Parkinson's, but not right at the beginning? But do you think we're heading towards a future where DBS might actually be used in earlier Parkinson's care?
Yeah, I would say that, we need to make sure that we're dealing with Parkinson's first and foremost, because Parkinson's can also, it's meant to be a slow progressive disease. But at the same time, we do know that there are also variations of Parkinson's, and we need to make sure patients are responsive to the therapy. So we at least wait a couple years to 3 years of having certain degree of symptoms, so that we know that they're progressing the normal routes, and then we would do surgery. So again, we don't want it too early in the disease state, but we do know that the earlier, the better, in the context of maybe we are dampening certain signals, maybe we're not letting things progress, maybe it allows patients to continue to exercise the way they're supposed to, live their life and travel, whatever it may be, and also feel less dependent on pills. And I commented earlier about that, but we do have the ability to lower the amount of medication 50%, 75% of what they're already taking. And there are a few percentage of people that are just off medicines altogether.
That's Amazing. So, well, I was actually going to ask you about that because I was going to ask how DBS fits into a broader care plan alongside medication, therapy, lifestyle support. How does it work as a whole?
So, as a patient with Parkinson's, you're taking your pills maybe in the beginning once every 6 hours. And then as the disease is progressing over the years, maybe it's every 5 hours and then 4 hours. And some people become very dependent. They're taking every 2 hours. So they are limited in their day to day. They're going out, they're with friends, they feel stuck, they feel frozen, then they have to take their pill and they feel good again. And they're going back and forth in this cycle throughout the day. And, uh, the loved ones, caregivers have to like be there, support them. When they get stuck and frozen, they have to put them in a chair, or they have to, use their time to kind of wait and let the medicines kick in so that the patient can feel good. Like, this is where DBS comes into play, is like you have a smoother day. You're not necessarily depending on the pills every couple of hours. Now we can actually lengthen the duration of the effect of medicine so that patients are actually getting artificially stimulated in the brain this way, that as if the medicine is already working. And it works even more efficiently than medicine. So patients who are now on deep brain stimulation, they're taking less pills. They're able to move better, more freer. The degree of their tremors is far less. The degree of their rigidity is far less. I had this patient, Ursula, who couldn't put on his pants. He took his pills, and even when his meds are working, he gets stuck. He can't lift up his pants. And after deep brain stimulation, he's actually showing me, he's like, we're in the office, and he's like, look at what I can do. And he takes off his pants and he puts up his pants just to show us he can put on his pants. And we take that for granted. And it's amazing what people can do when they're feeling good, when they don't feel like they can get stuck. And I want to also share, since we talked about a patient, have this cop who came in with his wife, and he came in on a wheelchair, and he is hallucinating. He's on medications that were making him feel like his wife's cheating on him. He was extremely rigid. And it was all because of over medication, because we're trying to control his symptoms, and his doctor was trying his best to help him, but the medicines were causing side effects. So I told him after the consult, look, we have to back off on the medicine. And the wife is concerned, well, then what about the tremors? What about the rigidity? And I said, look, we have to balance this out. So we started backing off on the medicine. It took 2 or 3 months to start backing off the medicine, and his tremors came back, but he was more awake, more alert, but he wasn't as tired, and he wasn't hallucinating. And we did neuropsych testing for him. And then we said, look, it was definitely not from his Parkinson's disease that he's hallucinating. It was from the medicine creating the problems. And then we confirmed with the surgeon that he's a good candidate. His heart was checked. He got the cardiac evaluation, and his heart's pumping fine, so he could manage the surgery. And we checked his blood work, and there's no other risk factors. So he went for surgery. He comes back, and we've been stimulating him. Now it's been 5 years since his surgery, and he's living his best life. I mean, they went on a vacation to Vegas. They were at another vacation in Cancun. And these are things that the wife couldn't even imagine that she would be able to do with him. So he's on way less medicine. He's able to think for himself. He's able to bathe for himself. He's able to swim. He's able to, feed himself, and all because deep brain stimulation allowed him to do that. And now with the adaptive deep brain stimulation, we've put on new parameters for him, and now it's even more efficient. The adaptive stimulation makes my life easier. I just give him a certain parameter. We've sensed his brainwaves, and then the system does it all for him.
That is astonishing. I mean, that's great. So, what advice would you give a patient who's heard or is hearing now about DBS, but is not sure whether or not it's for them?
The advice I'll give a patient and their family member about DBS is typically, here's a online web source for, like, say, Medtronic.com. Type in deep brain stimulation on a Google search and go to reputable websites. Michael J. Fox Foundation, maybe one, Parkinson's Disease Foundation. Listen to this podcast, wherever they can, come to our clinic, get a second opinion. But make sure you see a movement disorder specialist, number one. Okay. So movement disorder specialists like myself, we're the ones who are trained in how to program. And I help teach courses and I go to different lectures. And so I'll teach other doctors about it. So you really want to go to someone who knows what they're doing and how they're able to program. So that's one aspect of it is talk with other doctors, get a high level of care, go to support groups, talk to other people who've had it. Now, again, there's going to be the good and then there's going to be the bad outcomes, and you need to weigh those pros and cons. But there is the long-term care of Parkinson's and there's the short-term care. Now, deep brain stimulation after you've had the surgery, you may be a candidate for certain clinical trials, but you may not be a candidate for other clinical trials, because if you have deep brain stimulation, it does also take you away from maybe certain medicine trials because you look so good that you can't see a difference of the response of a clinical trial being benefiting you. So you do also want to understand that if you wanted to be participating in clinical trials, that may sway you away from DBS for the short term. But at the same time, long term, when you have DBS, you can still have access to newer medicines. You can still take other medicines. And if there is ways of, getting newer therapies, deep brain stimulation can still allow you to get that.
I have an even more complicated question now. What about those who wanna do it but would not qualify? Is there any way they could actually qualify in the long run, or those who do not are not going to?
So there's some patients who are dealing with schizophrenia, or they have some other mood disorders, or they're dealing with depression. We make sure that those symptoms are under control. So either they'll be seeing a psychiatrist or a psychologist. They'll work with us as well to make some medicine adjustments. But until the depression or anxiety until that's controlled, they're not a candidate. So we've had many patients who've had severe depression. They've met with their psychiatrist, and we have to also make sure that they're not going to in the future get like ECT, electroconvulsive therapy, that's electrical stimulation in a different way, because if they have a deep brain stimulation, we don't want that complication. But they have to be medically managed. As long as they're medically managed, then they can go back into the consideration for DBS. That's one. The other risk factor is if they're already falling a lot. You don't want someone falling and hitting their head and now having, the wire crack or have a bleed. So we make sure that someone's not as much of a fall risk anymore. But I had this one patient. She was a fall risk. She was having really bad tremor. And then what happened was, as the disease progressed, she's still having tremor, but she's not walking. So she's more wheelchair bound. So now she's actually less likely to fall because she's not actually initiating walking herself. She's again in a wheelchair, and there was other complicating factors with her back, and she was getting numbness and tingling in her legs, which it wasn't even the Parkinson's. Actually, it was part of her neuropathy that prevented her from walking safely. So now that she's more chair bound and bed bound, tremors are still bothering her to eat. So she went for surgery because now she's less of a fall risk. So there are things we can do. We do always monitor patients accordingly. But if the brain has severe atrophy, if there's scarring, if they're risk factors for tumors, or if they've had some form of radiation to areas of the brain, then maybe that's not going to be a future candidate for DBS, and it's just unfortunate. But we have to, again, always weigh the pros and cons, and we want to put people in the best situation.
Dr. Thakkar, thank you so much. It's been so enlightening. I think it gives hope to a lot of people that may be hopeless. So again, congratulations on having one of the biggest podcasts in the medicine field. Thank you. Again, thank you so much for everything you're doing. I really think you should be really proud of yourself.
It sounds great. Thank you. I've got a lot of good support. I work with some very good people. I appreciate where you come from, Ursula, and doing your homework and getting these questions, and the whole team at Top Health. I think you guys are very responsive in allowing me to use this as a platform. I think the one thing I also want to say, I've got a great team that I work with in my office. And I got support from industry as well, who has always keeping me on my toes with research. And I want to thank even Medtronic, who has helped me be a consultant for them. I've got to learn about the brainwave stimulation technology for the last 8 years. Actually, it just got FDA approved, but I've been working with Medtronic on the back end and learning about the technology and the platforms. And they come to me and ask what makes things easier for you and what's the best thing for you. And so a company like them, who's wanting to hear our thoughts, how to make sure our experience is good, and so we can offer it to patients. They even ask us what would make it easier for a patient. So we've even seen the patient programmers, we've even given advice about how the patient programmer should feel and look, and how the ease of use is. So there's a lot of different resources out there. I feel like this podcast for today may need an add-on deep brain stimulation, additional discussion later on. But for now, I hope everyone out there got a good taste of what deep brain stimulation is. And it does sound scary, but it is an amazing, amazing opportunity to control our symptoms and make us less dependent on pills. And yes, it's not for everyone, but it is so fascinating. So we are on the forefront of amazing technology.
Amazing. And for everyone who's listening, please stay tuned for episode 7 of the Caring Neurologist.